Hello everyone, in this video we shall discuss 10 flashcards in radiology. This is the first one, Buford Complex. Buford Complex is a congenital glenoid labrum variant where the anterior superior glenoid labrum is absent, that is from 1 to 3 o'clock position, along with thickened MGHL, that is middle glenohumeral ligament, and the thickened middle glenohumeral ligament attaches directly to the anterior superior glenoid, and this can mimic a displaced labral fragment. The clinical importance of this condition is it should not be mistaken for superior labral tear, and unnecessary surgeries should be avoided. This complex can predispose to SLAP lesion. The second flashcard is ACL cystic mucoid degeneration. The anterior cruciate ligament appears thickened and ill-defined. There will be increased signal intensity in all sequences on MRI. This mimics ACL tear. Mostly it is age-related degeneration. On MRI, the characteristic is ciliary stalk appearance, which is better visualized on T2 imaging. It is nothing but low signal intensity longitudinal fibers which are separated from each other by high mucinous material of mucoid degeneration and appear like a ciliary stalk. In case of mucoid degeneration, secondary signs of ACL injury are generally absent. The next one is frontotemporal dementia. Frontotemporal dementia should be used to denote the clinical syndrome caused by frontotemporal lobe degeneration. The patients usually present with changes in behavior, executive function, and language. In these images, you can clearly see there is a disproportionate atrophy of frontotemporal lobes. In this condition, you can even see frontoinsular atrophy, which helps in the diagnosis. The next one is grade 3 MCL tear. Medial collateral ligament injuries are one of the most common ligamentous injuries of the knee, and they are commonly seen in sportsmen. MCL tears can also be associated with other injuries like medial meniscus tears, ACL tears, and there is a grading system for MCL tear. Grade 1 is strainer sprain, grade 2 is partial tear, and grade 3 is complete tear. And differentiating partial and complete tear is almost impossible even on MRI, so it is often written as grade 2-3 tear. So in this image you can clearly see the disrupted MCL with increased signal intensity, suggestive of grade 3 MCL tear. The next one is hippocampal sulcus remnant cyst. These are also known as hippocampal cavities. This is an incidental finding, and it is because of the incomplete involution of the embryonic hippocampal fissure. These are small cystic spaces that follow CSF signal intensity on all sequences. These are present in between the dentate gyrus and cornu ominis. So this is a hippocampal sulcal remnant cyst. The main differential diagnosis for this is choroidal fissure cyst. This is the next flashcard, acoustic neuroma or vestibular schwannoma. It is one of the most common CP angle tumor that arises from vestibulocochlear nerve. In this image, there is an extraaxial lesion in the right cerebellopontine angle, which is intensely enhancing with few non-enhancing areas, and the tumor has intracranial extension, which is suggestive of vestibular schwannoma, and this appearance is called ice cream cone appearance. The cone part being the intracanalular extension, the ice cream part being the tumor. The point to be remembered is you can call this as ice cream cone appearance only when the size of the tumor is less than 3 cm. When bilateral vestibular schwannomas are present, it is highly suggestive of neurofibromatosis type 2. The next one is idiopathic intracranial hypertension. It is also known as pseudotumor cerebri. The signs and symptoms of this condition is because of the increased intracranial pressure. In this image, you can clearly see the tortuous optic nerves with prominent subarachnoid space around the optic nerves, and here on both sides you can see the stenosis of transverse sinuses, which is very important in diagnosing this condition, and partial empty sella is also shown in this picture. There can be other findings like tonsillar ectopia mimicking KRI1 malformation, and in some cases you can see the flattening of the posterior sclera and even intraocular protrusion of the optic nerve head, and even enlarged Meckel cave can be seen. The next one is mesotemporal sclerosis. It has the most common association with intractable temporal lobe epilepsy. Coming to the MRI findings of mesotemporal sclerosis, an FSPGR image you can see the reduced volume of right hippocampus when compared to the left one, and on flare sequence you can clearly see the increased signal intensity in the hippocampal region compared to the opposite side. The patient classically presented with history of seizures, and this is classic for mesotemporal sclerosis. There are several secondary findings in mesotemporal sclerosis, like enlargement of the ipsilateral temporal horn, atrophy of mammillary body and fornix on the same side, loss of normal interdigitations of hippocampal head, atrophy of the collateral white matter between the hippocampus and the collateral sulcus. 3D volumetric studies also can be performed to calculate the volume of hippocampus to diagnose mesotemporal sclerosis. T2 relaxometry is another useful tool to detect mesotemporal sclerosis. Here's the next image, Tarlow cyst or type 2 perineural cysts. These are CSF-filled dilatations of the nerve root sheath at dorsal root ganglion. It is mostly asymptomatic and diagnosed incidentally. These are commonly seen in lower lumbar, sacral and coccygeal region. In some people, it can cause neurological dysfunction and pain and is called sacral symptomatic Tarlow cyst. Nerve fibers are generally present within the wall of the Tarlow cyst and they are located often off the midline and enlarge the neural foramen. They follow the signal characteristic of CFSF on all sequences. There are many differential diagnoses like synovial facet joint cyst, dural spinal synovial cyst, etc. This is the last image, tuberculoma with meningeal thickening. This is a T2 weighted image showing iso-intense lesion with central hypointensity and surrounding vasogenic edema, and on contrast, this image is showing ring enhancement with thickened meninges. And these features favor the diagnosis of tuberculoma, and on MRS, most of the cases of tuberculoma shows lipid lactate peak. There are few differential diagnoses like fungal infections, metastasis, neurocystic sarcosis, and etc. Thank you. Hope this video is helpful to you.